our webinar on men who have sex with men, a discussion on prostate cancer care. This panel is a continuation of our Impact of Diversity in Urology series, which aims to start conversations on issues important to patients and urologists. This series was created as part of the Prostate Cancer Impact Alliance, or PCIA, a group of 40 diverse stakeholder organizations representing patients, providers, and industry. We are very pleased to have a fantastic panel today, but before I introduce our moderator, I just wanted to highlight a few housekeeping items. The first is that this webinar is being recorded and will be viewable at a later date on the AUA's YouTube channel. Registered participants should receive notice when that recording is available. This is also being streamed on our Facebook and Twitter handles to be viewed live and later on as recording. If you have questions for our panelists, please use the Q&A box. It should be located at the bottom of your screen. You put your message in the box and the moderator will read those questions to the panelists following the panel discussion. So that is to say that we will hold our questions till the end. If you're having technical difficulties, please contact Jay Labaro. Her email address is actually located on this slide. And then finally, I do want to thank our sponsors for their support of the PCIA and helping to make this panel possible. And with that, I'd like to introduce the wonderful Daryl Middledorf, an oncology social worker and founder of Male Care. And with that, Daryl, I will turn it over to you.
Thank you, Ray, and thank you to the AUA and all of its wonderful sponsors. Today, I'm deeply honored to represent both Male Care and the National LGBT Cancer Project in collaboration with AUA in presenting and moderating this discussion with 5 magnificent gay men and 1 magnificent fluid man who are deeply concerned with prostate cancer in our Pride community. After I introduce them, we'll get right into the questions and the discussion. Joining us as patient panelists is Lee Newell, who's a 73-year-old man diagnosed in 2014 with stage 4 prostate cancer, which metastasized to his bones. He's doing his best to outlive the 5 to 10 year estimate given by his oncologist at Moffitt Cancer Center in Tampa. And given the hurricane recently, we hope that Moffitt has survived well. Hugh McBride is coming to us from Ireland. He's an IT manager. In 2019, he was diagnosed with advanced stage prostate cancer, but he also continues to enjoy his life. And that's what I hope will be a major theme for today's discussion. Rich Radacchio is a social worker. He's director of clinical services at APNH, which used to be called the AIDS Project of New Haven in Connecticut. Rich has been living with prostate cancer since 2019, and I know Rich well because he volunteers as a male care support group leader. Joining us as physician panelists are Dr. Lamont Barlow, who's assistant professor of urology and pathology at New York University Grossman School of Medicine. He's interested in diversity in urology, serving as the diversity ambassador for the urology department at NYU. He's a member of the R. Frank Jones Urological Society and a member of the executive leadership team for Urology Unbound. Dr. Thomas Griebling holds the John Wolfe 33rd degree Masonic Distinguished Professorship in Urology at the University of Kansas School of Medicine in Kansas City, Kansas. He recently served on the AUA Task Force on Diversity, Equity, and Inclusion. And Dr. Jordan Bilbrew is a second-year resident at DMC Urology located in Detroit, Michigan. He is the first queer Black vice president of his medical school's Student Government Association. And fun fact, he was a professional singer in New York City prior to attending medical school. Hugh McBride, we're going to start our discussion with you. And so let me ask you, as you were going out for medical care for prostate cancer, did any of your doctors ask you if you were interested in having sex with men, women, or both? Or did they in any way ask you about your lifestyle?
Thanks, Darrell. The general practitioner or primary care physician raised it with me obliquely because she went to medical school with one of our senior politicians who's openly gay. So she started talking about him, which I took to mean she was assuming I was gay. So I confirmed it. And she said, listen, we will look after you, whatever you need, don't worry.
And when
when
you say she assumed, what actually constituted that assumption?
I don't know, but I think she had received my medical records from the UK when I had lived there, and I was an openly gay man in the UK. So it may have been on my medical records. I don't know, but I was a 59-year-old single man. So I think she was throwing it out there at least. You know, if it wasn't an assumption, it was, if I didn't take the bait, she would have gone with, well, he's heterosexual.
And did you feel comfortable discussing and disclosing your lifestyle, your concerns with your healthcare providers?
Certainly with my GP, yes. So that there was nothing really that I needed to discuss with her, because I made an assumption from way back in the 1970s, that the medical profession, their treatment in Ireland for being gay was ECT. Now, I was only a teenager at the time. Thankfully, I didn't undergo it, but a friend and colleague at school underwent that. So I was a little bit hesitant, you know, discussing my sexual orientation with any medic, because I didn't think they had an appropriate framework to be able to discuss it with me in a way that I would perceive as positive.
Sure. And for our audience who may not be aware, can you just quickly tell us what ECT refers to?
Oh, it's electroconvulsive therapy, whereby
Right.
they show you pictures of naked men, and if you get aroused, they give you an electric shock.
Right. And if you can imagine, there are countries that still practice this,
Yeah.
Central Asia, Africa, there are a number of countries. Um, Lee Newell, when you were talking to your urologist, did your urologist do anything to make you feel heard and understood? You know, Hugh mentioned that there was an assumption that he was gay. What do you think your urologist was thinking, and how did they make you feel respected and comfortable in discussion with them? Lee, if you're on mute, unmute yourself.
Yeah, sorry, the unmute, temporary unmute didn't happen. Anyway, it's a pretty loaded question for me, because as a single man with no one to accompany me, no one to listen, no one to witness, and no one to advocate for me, I was, I have not had very good experiences with urologists. Now, the first urologist who diagnosed me in 2014, now, first of all, about the gay thing. I mean, I was inducted into the City of Chicago Gay and Lesbian Hall of Fame in 2013. I started seeing the doctors in 2014 when I turned 65 and suddenly had health care through Medicare. So I'm an out gay man. I mean, so I went in and said right up front, I'm gay. If that's a problem, let me know, because I really don't want people who have a problem with me treating me. I'd rather.
And have any of your doctors ever said to you, yes, indeed, that is a problem, let me refer you out?
Oh, no. Everything's fine. Everything's wonderful. The first urologist, the one that diagnosed me, immediately established a rapport by saying, well, my father just died from prostate cancer. I know the entire process. I will be here for you through the entire process, which was a great comfort to me, since as I sat to have my blood pressure taken, I looked over and on the refrigerator was an Impeach Obama sticker. And if I went to his main office, I would have to sit for 30 to 45 minutes watching Fox News before I went back for my blood pressure.
So are you illustrating, and forgive me for interrupting, but
no.
I mean, we just have a ton of things and 6 people
right.
to talk to today. The idea of creating a welcoming and safe environment is important to you. It's important to anyone really, but as a man who's openly gay, and you're seeing Fox News impeach Obama, perhaps a presentation by the doctor of, just overemphasizing that they're open, which may betray an inner homophobic kind of presentation. I mean, all of these things sort of put up a barrier for you. Is that fair to say?
Oh, absolutely, absolutely. Then do you have?
Okay.
I want to trust my doctor. My current urologist, who I had a bilateral orchiectomy after 7 years of Lupron. I'd had enough, so I had the orchiectomy. But the urologist who did that, never occurred to him that I would want prostheses. I mean, this old queer, what would he ever do, But it bothers me because if I ever have the opportunity to be intimate again, I would like to avoid the whole discussion of, well, what's wrong down here and why, and while I'm dying, it's not a good way to establish intimacy. But when I said to my current urologist that I would like to have implants, he went into this long thing about how they don't exist anymore, and that what they use is wrong, and I wouldn't want it, and blah, 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 blah. And when I went home and checked up, it turned out that one of his colleagues represents the company that manufactures testicular implants. So what am I to say to him when I see him at our follow-up next month?
And we'll get into a bit, how to proceed with doctors once you feel discomfort for any reason. Rich Radacchio, did you feel that you received appropriate care as a gay man with prostate cancer?
I'm in a different situation than Lee. I showed up to a lot of my appointments with my husband, and I think that, and my daughter, adult daughter, who's also an APRN, especially when visiting with specialists like surgical oncologists and medical oncologists and radiation specialists. But with my urologist, I always had an open rapport. He was referred to me by my infectious disease doctor. I'm also HIV positive, so I work in the HIV/AIDS field. So I'm very well versed in presenting myself and discussing health issues for gay men. So that was always kind of part of the discussion. Although that subtle innuendo or sense that the treatment was impacted by bias, I think was clearly evident. That my original urologist, which I ended up firing just before I started the radiation treatments, was not really. I had an aborted prostatectomy. When I showed up for my follow-up, he asked me what it was like to not have my prostate anymore, and I was like, it was a pretty significant, unusual thing to happen. And it was clear that he had not read. He said he started the appointment by saying he had read the report, but obviously didn't read it fully enough. I happened to have been wearing a Provincetown shirt, and as I was leaving, he saw Provincetown. He said, "Oh, Provincetown, how cliche." And at that point, it was like, there's the, that was kind of like the overt thing that was evident, that there was just this sense that because of my sexual orientation, there was a difference in the amount of attention or time or care that I felt I received.
Sure, and let's stick with that for a brief second. People will challenge gay men, bisexual men, queer men, when they say, I don't feel I was treated in the same quality of care that a heterosexual man with prostate cancer would be. How do you know that? How do gay men understand whether or not they're being treated appropriately?
I'll give you a specific example. The pre-surgery class that I went to had 2 straight patients as people that were on panels that talked about all of the different things that this prostatectomy was going to involve. And nobody through the course of the hour and a half talked about the loss of ejaculation as one of the things that would happen as a result of this surgery. So I raised my hand, and my husband sitting next to me got a little red faced, but I raised my hand and I asked, and one of the straight patients said, "Oh, my wife loves it. There's no more mess." And so I had to say, well, some of us enjoy the mess. And you know, the fact that there are elements of my gay life and my sexual life that are just assumed that we're not going to discuss it, or we're not going to talk about the fact that this may have an impact in my life. Another example, and I know this is about radial oncology, but through Health Unlocked, I was reading a lot about one of the things that, about radiation treatment and sexual practice. And it was clear that I should put nothing up my butt during that phase for 2 months after radiation. I had to bring that to my radiological oncologist and ask him. So I've read that I shouldn't engage in any anal receptive practice. And he was like, "Oh, yeah, I guess that's true." And, it just felt like I shouldn't be the one that has to educate my physician about what my practices are and how this treatment that you're providing me impacts my life.
Indeed, there is a bit of an unfair burden on people from any minority group, but today we're talking about our community, to have to teach doctors what fisting refers to, or
Right.
joy of ejaculate play, etc. And when you mentioned Health Unlocked, just to clarify, that's Male Care's support group platform. Everyone go to healthunlocked.com and you're
Yeah, the
free.
message boards are really, really helpful, both
Yeah.
for posting questions, and updates, and all other people with similar experiences. And there is one of the platforms is for gay men and prostate cancer, and it's been really helpful for me.
Hugh McBride, you're in Ireland, you're in Europe. Do you feel that barriers to care for gay men are comparable to their toxic quality that we find here in the United States, or perhaps Australia, New Zealand?
I think they're probably fairly similar. The one that got me was a nurse turned around to me and said that I shouldn't be coming for my radiation treatments to the hospital alone. And as far as I was concerned, I'm a self-reliant, capable, single man. Who did you want me to bring with me? Why can't I be sufficient? I'm sufficient for me. Why couldn't I be sufficient for the medical community?
Yeah, good point. Lee Newell, what have, just as Rich described, having to explain ejaculate play and things like that, and understanding the doctor, perhaps innocently and well-meaningly, but nonetheless still practically useless around the topic around loss of ejaculate or anal receptive sex. Lee, what have you found yourself having to literally explain to your urologist regarding your lifestyle? Yeah.
Actually, when it comes to urologists, they don't want to talk to me about sex at all. No. That's something that has never come up with one of my urologists. It did by chance come up with my very first local oncologist when I asked him if it was okay for me to have sex. And now this is a Hispanic man, not long out of college. I thought I would be safe with him. I'd introduced myself as a gay man. It was no problem. And when I asked him if it would be all right if I had sex with, he freaked out. I mean, absolutely jumped back. Oh my word, no. Semen's full of testosterone. It'll kill you. So that's what he told me, that I could never be intimate with anyone ever again.
How did that make you feel?
I was destroyed. I was destroyed. It took my therapist about 3 months to get me to the point where I could find out the truth, which is that there's no testosterone in semen. There was nothing wrong with having sex. It was again, repressed homophobia, where it was perfectly all right to deal with you as long as you don't be gay. Whatever you do, don't be gay, but it's fine if you are gay. Just don't act gay. Don't talk about being gay. Don't be gay, but it's all right.
Right. The idea that we treat everybody equally as long as they're heterosexual people. Yeah. Rich, let's go back to you. You work with AIDS patients and HIV patients. You yourself are positive. Do you think that urologists and those that you've experienced or those you've heard about through the support group or however, do you think they understand the barriers to care and stigma with the same power and empathy that doctors who take care of HIV patients provide?
I don't think so, mostly because of the AIDS crisis through the 80s and 90s. Most of the physicians that get into HIV care, even if they're younger and didn't, go through that period of time, are in a field where the norm is to be open to allowing patients to be the experts of their lives and to ask questions. For example, in the infectious disease world with monkeypox happening today, I think, they're just naturally, trained to, have a sexual inventory, a sexual intake and understanding of what sexual behaviors are. I personally would think that urology would also have that, for men and women because of the anatomy, and what we're talking about. But I haven't found that. After I fired my first urologist, I was referred to another that was more of a sexual function urologist, and there too it was mostly only focused on my being able to get an erection, as opposed to the whole impact or experience of gay sex, and obviously needing a firmer erection for anal sex as opposed to vaginal sex. That was something that really wasn't addressed or discussed. I was part of the Restore study, and I know the findings of the Restore study were not in line with what I found. I was able to maintain my ability to have an erection that was, firm enough to engage in being a top insertive sex. But that I showed up at the urologist's office and I explained that I was able to maintain erections, and he said, "Why are you here?" I said, "Well, I just want to have an established relationship as I go forward, recognizing that sometimes that function can change as a result of radiation over a longer period of time. So I wanted an established relationship." But even still, it was like he was scratching his head saying, "Why are you here if you're able to get erections?"
Yeah, and having a good relationship on a long-term or at least medium-term basis with your urologist,
Mhm.
even if you advance to an advanced stage disease
Right.
and start navigating with medical oncologists, et cetera,
Yeah.
it's still good to keep in touch with the urologist. Given your unique experience with HIV/AIDS doctors, let's be helpful with this.
Mhm.
What have you seen, learned, heard, or what helpful hints can you offer the GU urologists in our audience watching you right now?
Mhm.
Tell them, what do HIV/AIDS doctors do that urologists should do as well?
Yeah. And I would just add, not all infectious disease docs are really well versed in HIV care. So I've had the situation of being asked if I've been good, as opposed in terms of my sexual behavior. In other words, having a single sexual partner. I think really getting extensive training about what a full sexual intake inventory is, and how to you know address your own biases about what's right and what's not right. Recognizing that, especially I was married to a woman for 23 years, in the closet, came out. I had some other experiences in that coming out process. It became HIV positive. So I had a whole continuum of what normal sex was from a doctor's point of view, as well as what out of control sex was. And I think the thing I would just say is check your judgments at the door, and just see another human being in front of you. And if you can't do that, then really, as was suggested before, I think what Lee said earlier, or was it Hugh, that any doctor that I've seen will say that they are gay sensitive, that they are able to work with gay patients and feel like there's no bias. But
Well, let's and forgive me, we just have to keep.
Yep.
I got to keep pushing.
Keep going.
So let's ask some of our doctors about this. Dr. Barlow, tell us, do you think LGBT doctors are more likely to ask their patients about lifestyle and sex partners and fantasies and goals?
So yeah, definitely. So I've experienced healthcare on both sides, and from having my own providers, both straight and gay, I've noticed differences, and I think some of that just translates naturally. I was, I think, fortunate that in my generation of medical training there's a lot of attention towards taking more broad sexual inventories. NIH actually has guidance on this that most medical schools are now adapting about how to take a thorough sexual history. I mean, a lot of the buzzwords of just being able to rattle off, do you have sex with men, women, or both? Like I think it was mentioned once earlier now, which actually in itself is still not perfect because it doesn't account for other gender identities. And a better way, I think, would say, what are the genders of your sexual partners, and leave it as open-ended questions are always better. But yeah, I definitely think it's impacted for me. I think that it is helpful the more we just normalize, even in the way we present patients amongst ourselves, that it's a part of the presentation of a patient. But unfortunately, I mean, we know that urologists are still not doing a good job of this. I think there was a survey done a couple of years ago that showed that over 60% of urologists still don't ask their patients about sexual orientation. And when you're dealing with a condition like prostate cancer, that one of the top impacts is sexual function, and that's just really, you're missing a need if you don't really account for that in every patient you have.
Right, and you know, those surveys that they vary from 60% at the low end to 80 and 90% at the high end. And you know, the idea of I mean, MailCare came up with ask your patient, did they enjoy sex with men, women, or both? Over the years, and we came up with that like in 1999 or 2000, we've learned that is indeed inadequate. It misses fantasies, goals, people in the closet, people on the down low, etc. Now, for everyone watching, the question really should be as simple as a doctor asking their patient, tell me about your lifestyle. You know, it's open-ended, it's friendly, it's warm and fuzzy, and it's useful for the doctor in doing a shared decision-making construct with their patients. Dr. Griebling, what are some of the barriers in your practice that you've seen that are faced by patients and in the hospitals that you've worked in?
Yeah, I mean, I think the biggest is just the sort of heteronormative assumption, and not really thinking beyond what society sort of tells us should be. I remember even being in a group working on developing educational materials for another professional organization, and they wanted to develop patient scenarios. And one of the scenarios was a patient with prostate cancer presenting for their initial evaluation. And, it was looking really at caregiver issues and some other issues related to aging. And they basically just said, well, we'll have the patient come and it will be with his wife and they're going to get evaluation of this. And I said, why can't we have the patient in this scenario come with his husband? It raises a whole different area of questions. And, they really had never thought of that, and they really embraced that. And so that's what we did with that particular educational item. In our own practice, our staff have cultural sensitivity training that's required. We have gone to great lengths to make sure that our intake forms are inclusive. We make sure that people respect pronouns. We have a fairly sizable trans clinical service that we offer. And so we try to work, very carefully with those patients. But I want to go back to what people have talked about. I think especially it requires a level of sensitivity. And I'll remember one patient from early in my practice. A lot of my work is in female urology and voiding dysfunction and incontinence. And I remember a woman coming in with her wife many years ago, and my patient was going to need surgery. And we had a very explicit discussion during their preoperative visit about their sexual practice. And we talked about what the postoperative recovery would be. And, we talked about what they could do in terms of intimate and erotic play, and how long penetrative sexual activity would be limited based on that surgery, from vaginal surgery and things. So I think just developing a rapport, not just saying, oh, I'm okay with gay patients, but really learning about what people do and what our lives and our lifestyles are like and how we practice our sexuality, and understanding that. Rich talked about receptive anal play. And, I think often people may not think about that. But for patients undergoing radical prostatectomy or radiation therapy, very important to talk about that and how that will impact them. So.
Right, you're an out physician. People around you know that you're a gay man. I presume at your practice, at your workplace,
Correct.
do heterosexual doctors come to you for, can I ask a quickie gay question? I've got a gay patient in my office.
I do. I have that occasionally. There's a small group of out gay and lesbian physicians, here, and we do share some patients, but we also talk with our other clinicians, and they do ask those sorts of questions. I think the other thing that happens that I've certainly seen is, as you become known in your region and your community, you start getting referrals from other clinicians, but also from patients who've had a good experience. They talk with other people in the community, and I know I've gotten a lot of patient referrals that way throughout my career.
Excellent. Dr. Bilbrough, do you think when a gay man is trying to find a urologist to work with, a newly diagnosed gay man, either, with a primary presentation or advanced stage, he still doesn't have a urologist. Do you think he should actively seek out another gay a gay urologist, or or I mean, how do you think that should play out?
It's interesting. It should or should not. And I think I've seen, in the gay community, and I've seen also in the Black community, it tends to be an important factor on how you're going to receive information, how you would like to give information to people. And so, should or should not. For myself, I don't necessarily think that I need that, but I also am someone who I feel very confident in my character, who I am, and how I want to explain myself. But there are people who I do think that it will benefit them, incredibly, to know that you're walking into a situation where at least the odds of you being able to be more open and being able to, again, receive information is more in your favor. But regardless, you still walk into situations, we've heard already today, that there are, many physicians who it's a great soundbite to be gay sensitive or to be receptive to different lifestyles, but when it actually comes in play, as we've seen before, it doesn't always work out that way. So I think it would behoove a lot of people to seek that, so that they can have hopefully a more streamlined healthcare experience. However, we live in a non-perfect world where even when people do say that they are gay friendly, or even they are gay themselves, it's not always a perfect system.
Right, and we should acknowledge there are people who live in small and rural areas, or the area may be large, but the town they live in might be small, where they don't have the opportunity to find doctors of diversity and such. And there are, as you just touched on, there are many LGBTQ physicians of both genders, of all genders, who just are not out, and don't want to be. And it's probably not fair for a patient to pull them out. Um, but good allied doctors are hard to find, and hard to know when they're sincere, and hard to know when it's really a marketing ploy or an attempt at being sincere that just hasn't achieved the levels that a patient genuinely needs.
And you bring up a great point with being sincere,
Mm-hmm.
LGBTQ people, Blacks, any other minority people, we're very hypersensitive. We have experienced this this life for all of ours. We have experienced people who have, on the face value, have said that they're here for us, but we've also seen the same people stab us in the back in the same. So we're working with a group of people who they're not just your average, day to day. They can see past the words, they can see past the stickers on the wall, they can see past the safe space sign. And when you get to that that interpersonal encounter, everything else goes out. You're now with a person in front of you, and you're able to feel from them how actually open and inquisitive they are about your health.
Yeah, Dr. Barlow, and also Dr. Bilbrow, you could chime in on this as well. The idea of intersectionality, of men of color who are also men of the Pride community. There are times where the barriers to accessing care are more based on skin color, and there are some areas that still have healthcare systems that have elements of Jim Crow in them and such. What, Dr. Barlow, what have you seen? What do you think still needs improvement in the United States around helping men of color who are also gay?
Yeah, so I mean, I think that intersectionality and all minorities is an extremely important thing that we're all aware of. I mean, even just going back to talking about access to queer providers, I mean, across various different types of minority classifications, there's data showing that access to concordant providers improves care in objective ways. And so first off, I think even just doing more studies to prove that having access, and there's many patients who, like Dr. Bilbrow, maybe are empowered and don't feel like they need that, but just having access alone, like for my example of having a gay primary doctor that I feel I can bring up all of these things and not have to feel like I'm going to have to educate them, because we do have this minority burden, us as queer men, us as men of color, of sort of teaching the people around us that adds to it. I think just having a diverse workforce in urology, and this is why a lot of what the work that I'm doing to try to increase diversity in urology ends up like collaterally improving access and the quality of care that we give to everyone. But we have a long way. I mean, even just for racial, only 2% of urologists in America are Black, 4% are Latinx. It's getting better with training, but it's still really far behind. So we have a lot to go, but at least especially in the last couple of years, there's more attention, and even having webinars like this is a piece of progress. So there's more and more people who are aware of the problem and are willing to be a part of the solution.
Sure. And Dr. Bilbrow, you're closer to med school than any of us in terms of time. What have you seen among your peers that, and what have you heard among your peers of color and LGBT peers that they may be saying and noticing and wanting to repair that my generation of clinicians has failed?
Well, so I went to medical school in a small town in Central Oregon, where I was the first Black queer student there, first Black student period. So what I experienced during the training process in medical school was there were a lot of us as students who were trying to introduce, at least to this medical school, and I have seen very similar experiences across the country. We were trying to introduce, I recall freshman year, first year, trying to introduce the idea of pronouns. Can we please ask about pronouns in our standardized patient encounters? And well, we were met with a lot of not backlash, but pushback, because there were people who were confused. They didn't know why, and they weren't exactly receptive to hearing the reasons why. I also started a diversity program to try to increase the African American population of our students, because I was the only one. But then again, we keep meeting a lot of pushback, because it seems like people either A, are not understanding, or B, are refusing to understand when the information is presented to them. And Dr. Barlow mentioned, specifically, there's percentages, there are values, there are cold hard facts that are showing some of these things, and they are not, I don't think they are being pursued as genuinely as I would personally want them to be. I know at my medical school is really rough, and I could imagine that other people are sharing that experience as well.
Sure. Dr. Griebling, let's try and fix some things with whatever resources and trainings that are available now. What do you see and offer or suggest to second-year residents, perhaps, as trainings that urologists can adopt to make sure that their places of work are more inclusive?
Yeah, I think, again, we do a fair amount of diversity training with our team. As we are recruiting our residents, we've made a great emphasis on trying to increase diversity. And so we're looking broadly across definitions of what that includes to try to have a more representative community amongst our trainees as well. I think having this type of programming, increasing awareness, increasing education in this. I know in my own medical school experience, there was very little. We had 2 full weeks on human sexuality, and basically there was sort of 1 day at most of a session related to LGBT issues. And so I think we're starting to see more education, and we need to continue that across all levels, both undergraduate medical education as well as GME for our residents and fellows, and ongoing continuing medical education for people that are out in practice.
Yeah, and it's good that we have emerging GME kind of coursework on LGBT cultural sensitivity, diversity, et cetera. It's good to have like 3 or 4 hours of training in medical school. It would be nice if there were 30 or 40, but there are also opportunities in the real world for learning. Pornography. I encourage every urologist I meet, every doctor I meet, if they're open to hearing this, go to a site like Pornhub or whatever, use your spam blockers as best as you can, and watch 2 or 3 movies of men having sex with other men, or queer people enjoying queer versions of sex in a variety, including trans people. There are books and novels and movies, some of which are kind of glossy and almost worthless to watch, but there are some hardcore good movies on Netflix and other channels that show what it's like to be a gay man in contemporary society in the year 2022 going on to 2023. And for those doctors who travel through organizations like Médecins Sans Frontières and do volunteer work in refugee camps and such, learn about the gay experience and the LGBTQ experience in other countries, which is entirely different. I mean, today you have heard Hugh talk about electroconvulsive therapy. I mean, this is a man living in a major city in Europe who has full knowledge and full inner fear of the idea that somebody's going to do a medical intervention that will try and change and alter the way they enjoy life. It's extraordinary. The CME courses don't cover real world experience as well as we'd like, but fortunately, there's enough stuff online now that any doctor could spend the next 3 hours after this seminar getting up to speed on a whole lot of stuff that they can't even dream exists. Dr. Bill Brown, tell us again, or tell us more about what steps you think urologists should be doing.
Yeah, absolutely. So, I think some of the easy answers, is creating a safe space, which looks different to a lot of people, of course, but creating a safe space, you know, some people see that as putting stickers of rainbows up, or messages of pride, or even just the safe space sticker, or etc. You know, I think those are all great, but I think that those are very superficial. And like I said before, that especially people like us we are hypersensitive of our experiences and how we're being treated. I mean, the interpersonal interaction is going to completely overshadow anything else you've set up in your practice, even if you have great intake surveys. So I really think the work is, and it's been touched on a couple times now, it's a lot of introspective, it's inner work. We have a lot of implicit biases that we grow up with. If we're out, if we're not out, people have a lot of personal trials and tribulations that affect how they view themselves and how they view their patients and other people. You know, there's a fear of judgment. I feel anxious and nervous speaking to some of my patients. I want to ask them about some of their sexual activity, but I also don't want to offend them. So I have to deal with some of that myself as well. I'm a pretty confident person, but I still find myself having some visceral reactions that could possibly be of detriment to my patient. So a lot of it is personal work. And I think if we remain open and we remain inquisitive, and I think Rich touched on this, and it was really important, that to be inquisitive, but also to follow through with that. Like you just said, there are so many avenues that we can find. We're living in 2022. I mean, there's YouTube, there's Google, I mean, there's Pornhub, there's literally every resource we could possibly have to educate ourselves. And if I go home and I didn't know how to take care of a patient with bladder cancer, I go home and I study that. That's kind of how it works.
And the idea that you, Dr. Bilbrow, perfectly wonderful, fluid human being, would even think that there might be a moment where you might offend a patient by asking, you know, or suggesting that they have man-to-man sex or something of that nature, or however you want to express that. The idea that it's not all the individual physician's issue. It's that society all across the planet thinks there's something offensive about being gay. You know, I mean,
it's an unfortunate truth, but we grow up feeling that, we grow up seeing that, we grow up experiencing that, and it's impossible for some of that not to be you know, pervasive into our own psyches about ourselves.
Introspection is the key to a lot of this. I mean, you could book read, you could learn, but you have to experience things. And I mean, you know, for heterosexual doctors who are going to watch some gay porn on Pornhub or the site of your choice, you know, not only learn from what these guys are doing, and, you know, and some of it are just fantasies that almost nobody's capable of doing, let alone actually doing, but understand what it feels like for yourself to be watching that, and then imagine what it's like for the gay patient in front of you to be experiencing your presence. You know, do they feel uncomfortable with you? And how can you cross that bridge or build that bridge so that nobody feels uncomfortable, so that you could just hang out and do medicine and good cancer care? Dr. Barlow, you're going to have the final sort of question around this. And it's really still playing into what we've been discussing the last 10 minutes. What advice, what hardcore suggestion can you offer up to heterosexual doctors watching this, or for that matter, doctors still in the closet?
Yeah, so I mean, I think that one of the things that is the most helpful in dealing with any of our patients is trying to throw out assumptions. I mean, I think as humans, we try to recognize patterns. We try to use our prior knowledge and apply that to what we have in front of us. But at the end of the day, that has a potential to hurt patients that don't fall into what many of the assumptions would be. So I mean, I'm a urologic oncologist and research oriented, and we talk about like precision medicine, and we think of that from more like a genomic standpoint and a biological standpoint. But I think having the same approach for the psychosocial parts of cancer care. Just that every patient is unique and they shouldn't really make any assumptions on what is the best thing for this patient in front of you. And just being willing to talk, ask questions, listen to your patients. And then the other thing too is just what's come up a lot is not just making assumptions, but we have to actively work to overcome some of the barriers that our patients are experiencing. I mean, we're increasing data on some of the barriers that men who have sex with men experience in prostate cancer care, and less likely to get screened. They are less likely to have support around treatment. There's stigma, all of these things that we have to actively combat. Like we talk about being like anti-racist, we need to be anti-discriminatory, to just really trying to recognize when you do have a patient that is a man or sex with men, gay, bi, however they identify, that it's going to take extra effort on your part, the same way that we'd have an extra effort for anything that is any sort of minority of a patient, to try to ultimately fix the injustices that already exist and inequities that exist. It takes an active effort. So that's really the best advice I can think of, and how I've tried to approach myself, and I think just how we can all be better.
That's super, and a wonderful discussion. We have time for some questions. Folks, type them in the chat, in the Q&A section on your Zoom panel there. First one is from an anonymous attendee. You don't have to write your names, but if you would, and this question will be for anyone on our panel. Do we know if stigma, shame, and biases in the healthcare system create barriers that prevent men who have sex with men from being tested for prostate cancer, or prevent men who have sex with men to seek treatment? Open to anyone.
I think so. One thing bringing to this is the whole age difference. I mean, I was 26 years old before I lived someplace where my existence was not a felony. I wasn't safe, but at least I wasn't going to go to jail. And that is so you run up to this thing about, well, why would I even go? Why would I? It's hard enough to come out to yourself, and it's hard enough to come out to your friends, but to come out to this doctor, this judgmental person, this person who's going to care for you, who you want to care for you, and you don't want to tell them anything that's going to make them against you.
Yeah.
I also think and we often educate on a small level. So I would give the example, I was on our compliance committee for many years at the hospital that looks at the appropriateness of billing and coding for specific procedures and making sure that things are accurate. And an administrator came into our meeting one day, she was there every week, but said that someone had billed and coded for a PSA level in a woman. And that was absolutely impossible, and that there was no way that that could happen. And I raised my hand and pointed out, I have about a dozen women in my practice who are trans women who still have a prostate, who need to be screened, and that there are trans women who have died of prostate cancer. So I think educating just even on that level. You mentioned spam blockers. When I first got here, I found out that the spam blockers were blocking, things out of my email with, penis and vagina and orgasm and things, until I pointed out to them that my NIH grant included many of those words and that they couldn't block those. So I think educating even just on a small level can help raise awareness for people.
I would add that I attribute my HIV care for saving my life with prostate cancer, because before I was HIV positive, I rarely went to the doctor, but having a relationship with a doctor that I saw every 3 months, every 6 months, the blood work, getting my PSA done, I was diagnosed, my PSA had not gone above 4 before my diagnosis. It was seeing the trend over the years before that there was slight increases, and then the increases started to get more rapid. And before my biopsy. So I would say absolutely that, in the LGBTQIA plus community that, if I don't feel comfortable, and I would just add about folks of color, the fact of the matter is many of them are not going to identify as being a man who has sex with men because of their own internal bias or their community's bias, even though many of them are having sex with their pastors or in their churches. So I think that whole experience of recognizing that it's not just the bias in the doctor's office, but the bias in the community and their experience they're bringing into the doctor's office. So I would say yes, but, and to that question.
Great. We have another question. And this, I believe, was for the doctors, but we could flip it around and include the patients as well. What was something that that you as a urologist have learned from patients that surprised them? And we could flip this around. What have you as a patient learned from your urologist regarding something related to being a gay man?
I think something that we've touched on a couple times here that I've noticed in my short career being a physician so far is that it's so important. We use this a lot in social justice to not yuck someone's yum, and it's a really simple phrase, but there are so many different ways that we do yuck people's yums, and that can be with our body language. It can be with someone mentioned that they mentioned insertive sex, and the physician kind of, explicitly was disturbed and or surprised. So I think that that's what I've learned, that so much, that gaining that trust and keeping that trust. And sometimes you're an actor as well. You are receiving information that sometimes does surprise you. You're also human, and that's okay to feel surprised by something. But again, it goes back to the introspection, being able to understand yourself and those visceral reactions. And I think that is what I have really learned thus far. You can gain trust. It's hard to gain trust, and it's very easy to lose it. And it's so vital, specifically for this job. I think Daryl, you mentioned that this is urology, or maybe it was Rich. This is urology. This is very intimate conversations, prostate cancer or not.
I think one thing that has surprised me is, or maybe not a surprise, it's something I'm learning over time, both from my clinical practice and just from friends who have sought healthcare related to something urological, is the thing that you assume is going to be the most concerning or the biggest personal issue for someone may have nothing to do with what actually is, and your priorities as a provider, or even the side effects, things that you're concerned about. I mean, it was already even discussed a few times, I think, when we were talking about Lee and the testicular prosthesis after orchiectomy or removal of the testis, or concerns about ejaculation, things like that. That we really, the things that we may be concerned about, or we assume that patients are concerned about, may have very little to do with what their primary concerns are. So I think it's really important, even when we're counseling before surgery, giving our options, to have that open space, really to open-ended questions. What's on your mind? What are your concerns about this? And I mean, that's really what shared decision-making is really about. A lot of it is finding out a patient's own values and priorities and incorporating that. And I try to push this in everything that we do. I mean, prostate cancer has a lot more data on shared decision-making and more of a history, but everything you do as providers, it's really, it's very important for us to just tell them what the numbers are and tell them what we are concerned about, but really find out what they're concerned about, because it really can surprise you, and as it surprised me many times.
Dr. Griebling, anything that surprised you from one of your patients?
Not necessarily surprised, but I think what I would take away is, and I like the way that Dr. Bilbrew said, don't yuck someone's yums. And I talk with our residents about that. There's no stigma, there's no shaming of things, and I'll see patients who come in who may have a sexual practice that we don't necessarily understand, or there's something that they're doing, and we just have an open discussion about, what that involves. I know I have patients, for example, who like to and find great pleasure in inserting objects, for example, into the urethra. What I try to do, and I teach my residents, and to try to work with the patient, is say, that's fine. Many people get great pleasure from that, but there are safe ways to do that. There are safe options and objects to do that. Let me teach you about the safe options. Likewise, when I've seen someone with a sexual practice that I may not be familiar with, I ask them to teach me about that. Tell me, how does that work? How does that give you pleasure? And help me to understand that so that we can make sure that you're doing whatever that is safely.
Excellent. And thank you, gentlemen, for this extraordinary conversation. Thank you to the audience for participating in it. Thank you to the American Urologic Association and its wonderful sponsors whose logos appear in front of you right now for supporting our community. I'd like to thank my colleagues at MaleCare and the National LGBT Cancer Project, who over the last 2.5 decades have braved death threats, nasty comments on their voicemails, and a host of other stigmas and bad language that we've had to endure just to get this work out. And with that, I want to thank Ray and the AUA and turn it back over to them.
Thank you so much, Cheryl, and thank you so much to all the panelists. I really sincerely appreciate you sharing your experiences and your perspectives. I definitely learned a lot. I've learned some new vocabulary words as well. So I really do appreciate that. And Daryl, thank you again for moderating and also helping plan this webinar. It's much appreciated. Hopefully with this conversation, we'll continue within the Prostate Cancer Impact Alliance, and we'll have other wonderful conversations in the future. And with that, this webinar is concluded. Thank you all.